As you are joining us, if you don't mind, please adjusting your name in Zoom so we can see your affiliation. That will be really great. It's helpful during our questions and answers, as well as, getting to see who has been able to join us. And if it's your first time joining our meetings, let us know. We welcome you. This is an open forum, and we're very excited to connect with you all today. We'll get started just in a minute. Thank you all. I see Susie. Thank you for saying hello. Cassie, Sue. Awesome. Wonderful. Thank you all for joining. Great. And I see Danielle. Awesome. All right, we'll get started here in the next 30 seconds or so. As you are joining, we encourage you to please adjust your Zoom name to add your affiliation. That will be a very helpful way to know who we have in the virtual room. Great, and as some of you have joined our meetings in the past, we encourage hellos via the chat, questions, comments. Perfect. We're getting a lot of activity. Love it. Welcome back to some of our returning members. Nice. Great. Thank you so much for joining. We're going to get started just in a moment here. 2:32 Eastern, we'll get started. All right, so it is 2:32 on my end, so we're going to go ahead and get started. Thank you all so much for joining our 5th Pilots Affinity Group meeting. We want to warm welcome you all. We're getting closer to that spring weather in the East Coast. So for some of you that are in this area, the days are getting a little bit longer, which is great. We are excited for today's call. I'm going to start with just some housekeeping. We want to welcome you all to our meeting. Due to the large number of attendees, every participant has been muted upon entry. We are recording this call, and all of materials, the recording as well as the slide deck, will be available in our Confluence page. We want to encourage everyone to actively participate in the discussion. We have a few modalities. You can use the Zoom chat. I see some of you are already saying hello. We welcome that. Get to know where you're joining us from. And you also have the raise your virtual hand feature on the reactions. And that's also a way to signal to us that you would like to ask a question or a comment live, and we can triage those as appropriately. If you are sending chat messages, please make sure that it goes to everyone so we don't miss them. And if you are having any technical difficulties, you can contact my colleague Demry. She's supporting us in the background. And as more members have joined, we kindly ask you to please adjust your Zoom name with your affiliation so we have an idea who we have in the virtual room. Thank you all for joining us. Here is today's agenda. We'll start with some announcements and updates from the Gravity team and then we'll segue into 3 wonderful pilot presentations. We really want to give our gratitude to Ocean, Thrive Hub, and May June for making the time, and they're developing really wonderful slides for all of you today and content. We'll kind of close out with some partnership opportunities and an open discussion. Again, we welcome comments throughout the chat. You can also raise your hand, and we'll wrap up the meeting to give you an insight of what's coming next month. So without further ado, we'll go ahead and move us along. Our standing agenda on antitrust practices. As you know, Gravity is tool agnostic. So we are agnostic to the systems and tools used to collect, exchange, aggregate, and analyze social care data. And we expect that our membership will comply with federal and state antitrust laws. We also want to thank our sponsors for allowing us to really have this forum to talk to one another. We aim to foster a collaborative learning experience for all pilot participants, observers, the gravity community at large. And our goal is to share with each other successes, ongoing challenges, being able to pair potential partnerships together, and be able to learn together while testing and piloting gravity standards. To give you a glimpse of where we are, this is a peer-to-peer learning forum, and really our focus is under learning and understanding the real-world testing of gravity standards. Today, we have 8 gravity pilot partners who are actively implementing standards, 12 pilot participants that are seeking partnerships, and majority over 120 as observers who join our monthly calls. From just a little bit of a highlight, promising practice highlights. We want to, we have shared about the 2021 ONC LEAP and Health IT project, specifically the University of Texas. They are doing some wonderful work and have implemented the Gravity Project use case through their FIRE-enabled social and health information platform project. We also have, in partnership with Firefly team, posted a blog on the Gravity website, which is very, very exciting. And lastly, there's an ONC blog that came out late in 2022 supporting, highlighting their support and mentioning of this Gravity Affinity pilot group. And now I'm going to segue into the wonderful work that's coming ahead, and I'll call on Sarah DeSilvi.
I am here. Hello.
Hi, Sarah.
Hello. My name is Sarah DeSilvi. I'm the Director of Terminology at the Gravity Project, and I'm really excited to just make sure everyone's aware of some of the really amazing things that are happening in our next phase of pilot work in 2023. Next slide, please. So this opportunity is really born of collaborations with friends. Everything we do in Gravity is born of collaborations with friends, but we have a really exciting partnership with our colleagues at Civitas Networks for Health. We formally announced a partnership to focus on implementation and education in the summer of 2022. And we're really excited to note that because of that partnership and building off that partnership, we have a RWJ Foundation focused grant opportunity focusing specifically on opportunities with implementation and public health and health equity use cases that we will now discuss more deeply over the next slides. Next slide, please. This is kind of a general grounding in the why of the implementation activity supported by RWJF. So as you all know, so RWJF are leaders in the health equity and data equity space. So their focus and their alignment with their mission and the mission of Gravity and Civitas is really to focus on strengthening capacity for sustainable cross-sector data sharing partnerships, developing co-designed approaches to implementation. Really, we always have tried to operate from a multiple stakeholder perspective, and we do leverage these kinds of collectives to achieve stakeholder feedback, but really leaning into co-design for some of our implementation materials. And there'll be a lot more coming on that shortly. That work is led by my colleague Jillian Annunziata, and will be more on that to come. Really developing and disseminating technical assistance and resources to inform implementation efforts. You can see that we'll be doing a really comprehensive revision of our Confluence to make it more navigable for piloters and implementers and members. And then also supporting critical insight for Gravity to ensure terminology and technical work streams address public health and health equity objectives. So again, the depth and expertise in RWJ and Civitas is quite deep here. So we're very grateful for the support for all of the work that I mentioned, and specific support with pilots that I'm going to talk about next. Next slide, please. So the focus of pilots, specific pilots, and we think about pilots like there are many, many different ways people are piloting Gravity terminology and tech across the ecosystem right now. So every time in rural clinical practice, I diagnose somebody with a term that didn't exist before, I am in a sense piloting Gravity terminology. So there are many people on this call are using gravity terminology. Many folks are testing capacities in the IG. But when we think about pilots, we think specifically in this kind of lens, we think about those supported pilots that are partnered with Gravity in order to facilitate feedback loops so that we can understand at Gravity whether we're getting our deliverables right. Does our terminology meet your use cases? Are we achieving our health equity and public health objectives? Does our IG meet your use cases? Are there things that we can learn collectively? So not just learning Gravity, community members learning from Gravity, but Gravity learning from community members to make sure that we're evolving our materials to meet your needs. So with that in mind, there is a specific pilot focus for 2023 supported by the work of the partnership of Civitas and RWJ, which is capacity building to advance health equity through the implementation of social determinants of health data exchange using Gravity standards. The RFP is actually due tomorrow, so we want to caution anybody. The RFP is due tomorrow and it's been out in the ecosystem for some time, but pilot sites will be notified on the 17th of March, and you'll see that work fold into this exact space, right? The pilot affinity group will continue to go on. We will continue to meet every last Thursday of the month from 2:30 to 4 o'clock. And we will be continuing to answer questions on the social, on the IG and on all different kinds of tier testing. We'll just be leaning in specifically to some communities solving problems regarding governance and health equity and public health, described a little bit more on the next slide. Next slide, please. So again, those pilot site focus really are thinking about tier 2 testing. Again, just a couple of 3 different pilot sites, specifically thinking about terminology from Gravity in exchange within communities who are really focused on trying to address public health and health equity use cases. Our intent is really to, based on kind of listening over the course of the last years on the really ground level problems about data sharing and governance and exchange and use that we know are existing in communities all across the national ecosystem. We really want to make sure that we're supporting communities in solving those problems. And this is what the grant from RWJ in partnership with Civitas allows us to do. So we do have an RFP process that will commence as soon as we receive all those proposals. We have a really wonderful, robust, and diverse stakeholder group to review those RFPs, again, to make sure we're equitable in our review. We had an info session that you can link to here at the hyperlink, and we can put it in the chat as well. Again, just think about us leaning very deeply into making sure that we're assisting communities in solving the real world problems they have right now in the work of social care to advance health equity and public health needs. Next slide, please. And then lastly, I just want to make sure that everyone understands, again, we mentioned this kind of on the first slide, but hearing from our community that we can actually improve our resources. We are focusing on a redesign of our Gravity education implementation resources. And I don't know if Jillian wants to speak here, but I'll try to address it in case she's not ready to take the mic. This, again, this work is led by our colleague, Jillian Annunziata. We're very grateful for her. So again, it's revision of our Confluence, revision of our materials, focus on making things user-friendly, enable for members to engage, and really centering community voices with co-design sessions to ensure that we get things right, which includes perhaps making materials have different kinds of presentation for different stakeholders. Like maybe the needs of a community-based organization are not the same needs as a health IT expert in the clinical space. So just leaning into our responsibility to meet stakeholders where they are, again, supported by the RWJ funds through our partnership with Civitas. Next slide, please. And then this is the structure, sorry, of the pilot affinity group. Again, so this differentiates the kind of general support through the grant and the focused support of the grant. Again, the pilot affinity group, this space is not going anywhere. We will all still be here working on similar problems and creating shared space for review. But those 3 selected pilots will get a little bit more support, just as the pilots sites through the ONC LEAP Award or the ACL Challenge Grant or the ONC Cooperative Agreement have. Those pilots we're about to hear from very shortly. That will be bi-weekly virtual TA, designated in-person regional convenings, because the problems that we identified that we're trying to solve are community-based problems. So we want to make sure we're meeting people where they are, and lots of peer-to-peer learning opportunities. Next slide. And I believe that is it. And now I'm passing the mic to my lovely friend, Jillian. She can go a little bit deeper into the elements of education dissemination if she wishes, but she also wants to talk about a survey that we're doing of the community, again, in line with making sure we get member feedback. Jillian?
Thank you, Sarah. Nice to be here with everybody. Welcome. So picking up on what Sarah said and the breadth and scope of the work that we have launched in partnership with Civitas to support the pilot's work stream and this call, we're just interested as we transition into this next phase in hearing from you, the community, to gather some feedback on this group itself, how to make it more interactive, more useful to you, and just overall thinking about it from a kind of continuous process improvement perspective, to hear from you, the community, as we transition into this slightly different phase, but continuation of the same work, and with the mindset of wanting to always improve and enhance how we better meet community needs. So that survey is being shared in the chat. Thank you, Demery, for linking it there. It's also linked in the slide that you'll get after the call. And you see the questions right there. It's very simple. It's just 2 questions. We're asking that you complete it by Friday, March 3rd. And we're very grateful for your candidness and thoughtfulness in filling that out to help improve for future processes. So that's all in the survey. And then I just have a few announcements, 2 related to ONC, which I'll state here. So as many of you have heard, and maybe some of you heard just more about this morning, ONC released their SDOH Information Exchange Toolkit on February 17th. It's been published. It's really exciting accomplishment. And we at EMI, a few of us are supporting ONC in launching a learning forum around the foundational elements in that toolkit. And we had the first of 4 of those webinars this morning. We had 250 members join, members of the community join from across the ecosystem to learn more about the information in the toolkit. It's a very valuable resource. And it's linked again in the slide and in the chat, as well as how to register for upcoming webinars between now and June. And then the second announcement there related to ONC is around another project that a few of us at EMI are supporting around an integration framework, an SDOH social care integration framework. So a guideline for implementers, policymakers, and everyone in between, standards developers, around social care work. And we're convening a listening session on March 13th to hear more from the community, to get initial feedback on the outline of that framework in its development phase. So you can also register there through the slide and the chat. Thank you. And then finally, there's an opportunity through NIH and the NIDDK division around an RFA that's been released, also related to pilots, interventions, and integrating social care and medical care to improve health equity. So it's very synergistic with the Robert Johnson Civitas RFP that Sarah just spoke about supporting pilot sites. And I just included some key information there about how applicants are strongly encouraged to consider use of SDOH data standards established in the Gravity Project, and to test interventions that involve screening and addressing adverse SDOH in a healthcare visit. So there's some time to reply to the letter of intent there. It's due on September 19th, and you can learn more by linking in the slide and the chat. Thank you.
Wonderful. Lots of information. Really want to thank you, Sarah and Jillian, for bringing all of this announcements and updates to the community. We're very grateful. And please let us know the link for the feedback worked. Just want to make sure that people have it. Maybe thumbs up, or just let us know if you were able to catch it in the chat. I know we sent a lot of links, so I want to make sure you get them.
I tried the survey, Gabby. It worked for me.
Awesome.
Thanks
it worked.
Perfect. To you and Demery for putting all those in there.
Wonderful. So given, the wealth of information and our end, we really want to try to connect you all with opportunities to continue your work. And if there's any way that, you can participate on this wonderful events, please do. And now we're going to segue into our second part of today's presentation, which is really hearing from the pilot sites themselves. I'm going to provide a little bit of setting the stage and being able to introduce them properly. So as you all will know, we have started this affinity group with a 3-tier level approach where we have tier 1, 2, and 3, the minimum requirement to be part, and really let us know feedback on the terminology developed, is being able to use the terminology. And then really tier 2 and 3 focus on the use of the terminology plus content and transport standards, inclusive of fire and non-fire transport standards. So we are very, very grateful for everyone's participation. And again, we're very open to feedback. Today, specifically, we have 3 sites presenting, and we thought we'll give you a little bit of background on how they got started. So starting with the ONC and HL7 corporate agreement that was executed in early January of 2022 with the goal of supporting 2 pilot sites, support the launch of this group, and the Fire IG SCU2 publication. So we do have one of them here with us today, Ochin, and they implemented, since they started in 2022, early in 2022, they implemented the Gravity IG SDU1. And as well, we have 2 participants from the Administration of Community Living Social Care Referral Challenge, which was launched in March of 2022 and officially culminated in October of March 2020 and culminated in October of 2022. There is a press release if you want to hear a little bit more about all the finalists. For today, we have Thrive Hub, which is one of the grand prize winners, as well as May June, one of the organizations part of the Firefly team, and in partnership with Open City Labs, there are a bonus phase and a grand prize winner. And segue a little bit on what they're going to talk about today. So Ochin will kick us off. They will present on their experience documenting and tracking social determinants of health related interventions via the task and service request profiles within the IG. And specifically, they have implemented the Find Help Native Plus Fire integration through their Ochin Epic instance via the Compass Rose module at one community health center in California. Then we'll hear from Thrive Hub, which is a HIPAA compliant single sign-on community care hub platform that has web-based and secure capabilities that allow users to access multiple resources in one place. As mentioned, they are one of our the ACL Social Care Referral Challenge winners, and they will be conducting an introductory presentation today. May June will be presenting on their questionnaire, an app, as well as Firefly, which is an open source solution that helps connect the FHIR standards for healthcare interoperability to Google's open source Flutter framework, and they will be able to dive a little more into their wonderful work. So without further ado, I'll pass the mic over to Danielle and Anthony.
Thanks, Gabby. Can you hear me okay?
Yes.
Right. Perfect. Well, hello, everyone. I'm Danielle, Senior Project Manager here at Ochin. I am joined by Anthony, which is Ochin's technical lead on the project. Ned is our Director of Social Determinants of Health and was unable to make the meeting today, but is super eager to view the recording after. All right, let's go ahead and go to the next slide. So just real quick, I wanted to give the group a view into Ochin. We are a nonprofit healthcare innovation center. Our solutions include hosted Epic instance for our members, along with clinical support services and research projects. For our pilot summary, Ochin worked with one of our members in California to set up and test the closed loop referral functionality through Ochin Epic, which is our Epic instance for our members. Our main goal was to successfully implement the functionality, test it, and offer it to additional members once the pilot was completed. Business drivers behind us doing this is really to decrease admin burden for the clinicians, improve coordination of care, and enhance patient care delivery. And throughout the presentation, we'll kind of show you where we were at and where we're at today based off of completing this pilot. Go ahead and jump to the next slide. I'm repeating a lot of what Gabby already said here. The use case of documenting and tracking SDOH related interventions to completion is really the background information for our pilot. Our partners included Epic, Find Help, and one of our members who resides in California. Go ahead and jump to the next slide, and I'll get a little bit more detail on the ecosystem. So this is the pilot ecosystem. Epic is the organization that owns the EHR system. Ochin Epic. So Ochin, we have our own instance of Epic, which is maintained by Ochin for all of our members who fall under that instance. Our members who utilize Ochin Epic include ambulatory clinics along with acute care, which we are just now onboarding to Ochin Epic. The referrals are sent through an Epic program called Compass Rose. This program is used to enroll patients for care coordination. Last is the vendor, which is Find Help. They supply the bi-directional platform to send and receive referrals from clinics and community centers. And jump to the next slide. All right, so we tested the domains of food, housing, and transportation using the task and service request profiles. And jump to the next slide here. All right, so for the next two slides, we're going to speak to two workflows. The first one here is the functionality that Ochin Epic members were using to send and receive referrals prior to the Gravity Native Plus pilot. This unidirectional functionality allowed members to send referrals out of Ochin Epic to Find Help and then to the CBOs. The members would need to log into Find Help, which is outside of Ochin Epic, to get the response from the CBOs, and then would have to go back and document that information into Ochin Epic. So as you can see, it creates many steps to determine referral status and update the charts to keep everyone in line with the coordination of care for the patients. For this new bidirectional functionality, Find Help offers Native Plus, which is what Anthony is going to go over in this slide. Let me hand it to you, Anthony.
Thanks, Danielle. So where the last slide showed the previous workflow, this diagram shows the new integration. It summarizes the data flow, the app updates, and user interaction. There are different swim lanes at the top, which I'll go over quickly. The first is the end user at the referring organization. The second are actions in our EMR that send or receive data from Find Help. The third is the data transfer. The fourth is the Find Help platform, which is a web portal where the CBOs can log into and view their service requests from us. The last line is user interaction by the patient and the CBO. So to start the process, a user in the EMR completes an SDOH screening. When needs are identified, the patient is enrolled in a program. The end user will submit a referral request by selecting the CBO within our EMR and providing relevant data for the service requested. Our EMR then invokes a web request to Find Help with information about the service request, task, and demographics. The Find Help app will then query our FHIR server for additional information based on the references in the initial bundle. And the Find Help portal will then be updated and the request will be visible to the CBO. So now we're on step one of the far right swim lane. The CBO can accept or decline the referral and provide the reason for declining, which will then send back to the EMR. For this example, let's assume the CBO accepts the request for the patient will receive an email or text alerting them that the service was requested. The Find Help app will also send a task.update back to our EMR, where the end users can see the updated status in the chart, in the program, and they'll also receive a message in their in-basket with the updated status for the patient. As the service goes through its life cycle of in progress and complete, the patient is updated via text or email along the way, and the statuses are continuously being pushed back into Epic. The CBO can invoke these status updates in the Find Help portal, or the patient can do so via their text or email responses. When the service is complete, the task gets updated to complete, the EMR is updated, and the referring team is notified. So this is our main workflow and data transfer of the integration for this project. Next slide, please.
All right, I'm going to take it back over here. For accomplishments of this pilot, just want to go over those real quick. Number one is just general excitement about this bidirectional functionality from our other OCHIN members. Based off the 2 slides there, you can see how much time it's going to save them to be able to do everything within OCHIN Epic and be able to coordinate those referrals. Second is screening questions were mapped prior to the pilot. Discoveries of the capabilities of communication, completion of work through task status, round trip testing with the pilot member, which we did run into a few items that Anthony will be speaking about. User guides and workflows have been completed for our new members to onboard to the new functionality. And as of tomorrow, the build will be moved to production with the pilot member, and then we're going to open it in March for additional members to start using the new functionality. Go ahead and jump to the next slide. We'll talk about some lessons learned. All right. Number one, resource constraints. I think we all feel that across the board on all projects. We did start out with 2 members to pilot with, lost one of them along the way. They're excited about the functionality. They just didn't have the time to put into it to pilot it with us. So a big lesson learned, if we want 1 to 2, next time we would probably start with 3 or 4, just knowing that so many people do have constraints. We did find inconsistencies between Epic and Gravity documents regarding fire resources and web services. Anthony is going to speak about that one a little bit more here soon. The OCHIN team struggled a bit in the beginning of the pilot to utilize the Gravity project Confluence site and documentation. So I think just kind of a lesson learned there is maybe a little bit more time in the beginning to really understand the documentation that was provided and really what the ask was behind it. The lack of CBO engagement helped us determine earlier engagement is needed when setting up the program. For this functionality, the CBOs have to accept this program. As we know, with resource constraints, it's been a little bit difficult to get them to engage to do so. So just another lesson learned as we onboard other members there. And then there's also instability caused by the build on the EHR end and fire artifacts, which again, Anthony is going to speak to more. Go ahead and go to the next slide. Then I'm going to hand it back to Anthony.
Thanks. Yeah, so we did struggle with a few data value and data type mismatches in implementing the fire integration. That definitely provided some additional lessons learned. The first was regarding consent.status. At the EMR build level, we have many available statuses that a user can choose to mark that the consent has been filled out and received. For example, we have signed, received, collected. They're all really adjacent to each other. On the Fire app client side at Native Plus, they were expecting a very specific status of signed only. So when we did the first application build, we didn't restrict the other ones. And this came up during testing. A user selected a different status than the one that the client expected, and the CBO never received the request in the Find Help portal. So the lesson learned here is definitely, review and confirm the expected values for these, very strict types like consent status or other artifact statuses that have adjacent options to them. The second lesson learned was we actually had a data type mismatch for our encounter period start. The EMR was saving data to the Fire server inconsistently, sometimes as date only, sometimes as date time. This is kind of alarming from a data integrity perspective. The Fire client at Find Help was only expecting date time, rightly so, because that is what was documented in the conformance statement. So we've engaged with Epic to have them review the backend code just to make sure that the data element is always fitting what it's supposed to be in the conformance statement. And I think all in all, the lesson learned here is really performing extensive QA, test every possible workflow because you never know when there's going to be an edge case that will error out for this type of reason. And next slide, please. So in reviewing our integrations for this project, we definitely found some improvement opportunities with some of the key FHIR artifacts in our system being used by the direct referral light workflow. Starting with the service request artifact, our EMR is only associating a single, very generic referral by service code instead of using an SDOHCC slice of category. In its place, our integration with FindHelp is using a communication artifact for the CBO to understand which services are requested. So in the EMR, the end user will type out what they're expecting with this service for the CBO to provide. And then on the vendor's platform and FindHelp, the CBO can see that message that was entered with the request and respond back to it. So we're communicating with Epic to build out additional functionality for associating the correct category slice. Even if it's not used for our current integration, it's definitely going to be helpful for quality reporting. And I think I saw a chat mention about, documenting the procedures that were performed, that kind of thing. For the task artifacts, our integration with FindHelp did not include a task focus to back reference to the service request. The current integration sends the service request and task ID to the vendor in the initial bundle. So functionality-wise for this integration, we didn't need to back reference the service request from the task. But in the future, if there's any other FHIR integration that we implement that will look at that task, they won't necessarily get the focus element to reference what the service request was. So again, it's that thing, while we didn't need it for the initial scope of this implementation, we're definitely starting internal processes to get this added so that our data is consistent. And finally, for the consent artifact, our EMR does not store the source or the organization element. Again, this is something we need to work with Epic on to get that source added. For the organization of the consent, our system, our EMR is organized in a way where the encounter organizations are assumed to be the custodian of the consents that they generate and that they use. So again, another example, we don't need the capability in the short term, but we want to implement it for future integrations and data consistency. I'd say all in all, the project really helped review the integrity and consistency of the FHIR artifacts used by our EMR. It's also provided extremely valuable insight on updates that we'll need to make at the EMR build level or the EMR capabilities level and the FHIR server capabilities level. We're really excited to use this feedback to kick off improvement processes to make our system more valuable, more cohesive, and better reportable for SDOH needs. We're also really excited to work with Epic on these changes, as this will benefit every organization who uses Epic and will improve SDOH interoperability for all. Next slide, please.
All right, take it back from Anthony. So just real quick, we just want to touch on the path forward from here. So short-term goal really is to get this pilot member live and them working with their engagement community specialists to get the CBOs to accept the program. And it's really a continuous effort as they identify additional CBOs. It's a real engagement, getting them to accept it and starting this referral program with them. We are aiming, once they go live tomorrow, to have the CBOs that they're currently focusing on to be complete and ready by the end of 2023. Long-term goal is to set up additional members and then gather and analyze the outcomes of the bidirectional functionality. Our main focus for this, as we spoke about in the beginning, is to help our members decrease admin burden and improve in coordination of care. So those are going to be the main factors when we're analyzing. Once we get additional members, it'll probably be a quarterly effort to kind of analyze how this is improving clinical care for our members. Go ahead and jump to the next slide. Pilot team, just another quick reference. As I spoke to Ned, who was our director of SDOH, was unable to join. Myself and Anthony were part of the project, along with Leah, who is another technical lead. And then we have Rhonda, who on the OCHIN side really is the brains behind our Compass Rose programs. It's not just one program, there's multiple programs that are really designed for our members to use. And then of course, through those programs is where you can send these referrals and receive the information back. On the last slide, just a couple of resources if you want to learn more about OCHIN. We have our website there, Find Help and Epic. So anything you would like to kind of dig a little bit more information into us, go ahead, feel free and look into those. Anthony and I will have to drop. We do actually have an internal meeting we need to get to. I do see there are quite a few questions. I'm not sure if there's one real quick, Gabby, if we want to focus on one or not, but we will have to drop and take questions via email.
Okay, if it's okay, maybe like 2 questions, Danielle, and then, all right, perfect. And then
We'll do our
try-
best. Let me say that.
There's one question from Carly Beck. Great work, team. Was it a manual process to map screening questions to diagnosis codes prior to the integration?
Yeah, it was. We have a very large table that stores all of that information.
Thank you, Anthony. And then I did see there's a little bit more granularity with procedure codes. So you kind of covered that one a little bit. So I'm gonna jump to Gabe and Matt. I promise we'll log the questions and get you answers post meeting. I did see one from Gabe for the OCHIN project. Are the CBOs logging their actions, accepting referrals, documenting services, etc., in Find Help or another data system? How many CBOs are participating in this workflow today?
Yeah, so the CBOs do utilize the standard Find Help platform and CBO tools to receive and respond to the referrals via the platform. There's many CBOs, so we have members all across the country. So really the piece of it is, as soon as a member is interested in this, such as our California member, they start working with the Find Help community engagement team and come up with a list of the CBOs that they've been working with, that they're focusing on, that would like this functionality with. So those are the top CBOs. And then Find Help also has a list of participating CBOs in each of these areas that would be helpful for the members. So that's really, and there are many, many CBOs, you know, it kind of just depends on the location that they're focusing on.
Great, thank you. And I think if it's okay, we'll handle some of the other questions a little bit offline. And some of the fire related ones, I think we can add to our frequently asked questions document that we're composing for the community. So again, thank you so much. I want to send the gratitude to Danielle, Anthony, the larger OCHIN team for the really hard work and testing standards and really being able to work with many systems to accomplish their work. So I just want to take a moment to thank you and very grateful to participate. I'm sorry we're keeping you away from your internal meeting, but really want to thank you for your time today.
Thank you. Thanks for having us.
Thank you.
Bye.
Perfect. Yeah. And we will segue into our next presentation. We are saving the chat to ensure that we have the questions received. So please don't be discouraged. We really do want to hear from you and learn with each other. So next we do have, oh, excuse me about this. I'm actually gonna stop sharing because Beth will share her own slide deck. Thank you so much.
Awesome. Can y'all see?
Yes, we can.
Fantastic. All right. Well, my name is Beth Franklin. I'm the Senior Director of Operations at SE Thrive. And I also have with me Katie Morgan, the Senior Vice President of Business Development at Protect Solutions. And together, we've been working on Thrive Hub, our pilot project and our project with the ACL Social Care Referrals Challenge. For our pilot, SE Thrive has been the project lead. We are the statewide nonprofit and host of Thrive Hub in South Carolina. Protect Solutions is our technical lead, the developers of Thrive Hub. And then we have Care South Carolina, a community partner who uses Thrive Hub and is also a medical provider in our state who uses eClinicalWorks as their EHR in South Carolina. And so SE Thrive is a nonprofit that helps South Carolinians navigate complex systems of available benefits, making sure that South Carolinians are able to access resources in innovative and efficient ways while positively impacting quality of life statewide.
And I'm Katie Morgan. I'm with Protect Solutions, and we're a nationwide systems development company in the social services space. And we do provide the underlying platform for Thrive Hub. In fact, Thrive Hub is our white label version of our closed loop referral system called Good Grid. During our almost 5-year relationship with SC Thrive, we've built out our platform to include applications for services such as SNAP, TANF, Medicaid, and many other programs. And we've also included things like document repositories, form builders, benefits cliff calculators, and much more, all designed to help those individuals come to one source for assistance and well-being.
So as this one-stop shop, SC Thrive uses Thrive Hub to simplify these complex systems of available benefits, making those resources more accessible. Recognizing that when someone is in crisis, the last thing they need is another complex system trying to find a resource. It could be easier, and that's what we want to make happen. So we meet people where they are, partnering with organizations all across the state, anywhere someone lives, work, plays, worships, is educated. And through Thrive Hub, users can access tons of different resources they may need in one place at one time, from benefit applications like SNAP and Medicaid, to case management tools, closed loop referrals, and so much more. Our pilot is based in the state of South Carolina.
So as we've noted, Thrive Hub is a social care referral system, plus a lot more. And in our initiative, we integrate with ECW, our eClinical Works, our EHR, to meet the client's needs. Through our collaboration with CARE South Carolina's social work and technology teams, we enabled healthcare workers to identify a client's social needs using a Prepare SCOH assessment on their EHR. Then we send the referral to the social care provider, and in our case, a food bank and a local council on aging group, while we create that client profile on Thrive Hub. That profile becomes that communication hub between the medical and the social care providers.
So as far as our business drivers, SC Thrive is looking at things like the services accessed by clients and patients. We're also looking at the number of clients or patients served, recognizing that those two numbers are pretty different sometimes. We're also looking at depth, breadth, and diversity of our partnerships. So what kind of partners do we have? How deep do those partnerships go? And then partner activity. We look both at a point in time and also engagement over time. So is that engagement increasing? Are those partners using the software more, but also are they helping clients access multiple resources at the same time? As far as some of our other business drivers, I have a video that I'll talk y'all through. So what if we could connect healthcare providers and social care providers in one place? What if we could make it just a teeny bit easier for our community members to navigate these complex systems of available benefits? And what if we could reduce duplicative work and provide true holistic health analytics for communities? With Thrive Hub, we hope to do that. Thrive Hub is a South Carolina system hosted by SC Thrive, and our model is built on fostering high trust relationships with a wide array of different types of organizations. These could be federally qualified health centers, homeless shelters, hospital systems, food banks. It could be state agencies, places of worship, and so many other types of organizations. We know that Thrive Hub has the potential to be an incredible, powerful platform for change in our state. And we know that it's a South Carolina specific system, including South Carolina specific applications and things like that. It helps connect social care providers and community providers all together in this one place, this one software. And through our work over the years with Thrive Hub, we recognize that technology can be used to break down barriers to quality health. So our partnership with SC Thrive and ProTech is based on doing that. We know that software such as this has the potential to multiply the help a community member can receive exponentially, all the while addressing health holistically, and knowing that it takes not just healthcare providers, but a network of community providers as well. And we can also see that when a client is in need, a lot of times they're reaching out to these different organizations one by one with that unnecessary complexity. Getting help could be and should be easier through the use of technology. We know that in this process, community-based organizations can often be a missing link in someone's healthcare journey. We completely believe in Thrive Hub's unique combination of elements and their ease of use, recognizing that it's more than just referrals or applications. And we understand the challenges specific to South Carolina and know that everyone working in these different sectors is working together to help South Carolina.
So Beth really summarized the why we wanted to participate in this project. And over the next couple of slides, we're going to talk specifically about our pilot. First of all, we're a Tier 3 pilot participant, so we're using both gravity-defined coded concepts and exchange standards. Our pilot has 3 key components. First, we wanted to be able to securely share SDOH screening outcomes between the social and the healthcare providers, with patient consent, of course. Second, we wanted the medical provider to be able to send referrals for identified needs to a social care provider and then get back the results of those referrals. Finally, we wanted to be able to track the patient outcome across providers. Now, our testing period began last March and will continue through this upcoming April. We like to consider all of SC Thrive's network of agencies as our partners in this program, as they're using Thrive Hub. And they're the receiving and processing entities for all of these SDOH referrals. But for this pilot project, of course, CARE South Carolina and our food bank provider are our key partners. I would like to point out one differentiator in this project, and I really think it refers back to some of the things that Ochin said. One of the key reasons that we so enjoy our partnership with SC Thrive is that SC Thrive is equipped with a contact center that clients can call into to receive services telephonically. They also have regional staff and a training team that helps ensure those CBO providers have the resources they need to fulfill the SDOH requests. Next slide, please. So for our pilot, we check almost all of the boxes for this pilot system. And next slide. Although our system does cover all of the SDOH domains, our pilot specifically calls out food insecurity with our referral between the community health care worker and the food bank based on the needs identified in the prepare assessment. This slide represents our crosswalk of terminology. And as we noted, we are a Tier 3 project, so we're using both gravity-defined terminology and exchange standards.
For our pilot ecosystem, we have several different types of partners, so a lot of whom we've mentioned already. So ProTech Solutions being that technical partner, CARE South Carolina being the clinical partner. For our community-based partners, the referrals are with North Strand Helping Hand, which is a local CBO in the area that CARE South works in. The SC Thrive Contact Center, where Katie mentioned, individuals can call in and apply for SNAP or Medicaid via the phone. And then the PD Area Agency on Aging, also known as CARE South Vantage Point. And all of these partners are using Thrive Hub, with CARE South and Vantage Point using eClinicalWorks as well. And then to walk y'all through the actual pilot workflow, we're going to look at a specific case for a patient named Rebecca. So Rebecca lives in the PD area of South Carolina, and she's had a couple of dizzy spells over the last week. So she schedules an appointment with her local FQHC, Care South Carolina. When she goes to see the doctor, he informs Rebecca that she's diabetic, and refers her to a community healthcare worker through their EHR. That community healthcare worker is also a Care South Carolina employee. And so when Rebecca and that CHW meet, that CHW will conduct a social determinants of health assessment, that prepare assessment, and start a referral in their EHR with those diagnostic codes. Thrive Hub receives those details on Rebecca's referral and sends a service request to providers in the network who are receiving service requests for that specific type of service. And then closing that loop, those service providers are able to respond to the request, follow up with Rebecca, and provide updates and outcomes to whether or not Rebecca received those services.
Okay, so Beth gave you the basic workflow from a use case perspective. I'm going to walk you through what that looks like on a technical flow chart. I'm going to start over at the left, go over the top, and then close the loop at the bottom. So starting at the far left, the Care South caseworker assesses the client using the Prepare tool in eClinicalWorks EHR. From the information in the Prepare assessment, ECW will send patient demographic data, the encoded Prepare data, and the community referral data with Z codes to Thrive Hub through a HISP secure email. Thrive Hub will receive the data and create a client within Thrive Hub, and then send a social care referral to our community partner. The partner can provide services as well as utilize other system tools on behalf of the client, such as applying for benefits, establishing a wellness plan, and the like. Once services have been provided, the community partner enters the outcome data into Thrive Hub. Thrive Hub then closes the loop by sending the client demographic data and the referral outcome data back to eClinicalWorks using EMR Direct and HL7 standards. So our testing, some of our pilot logistics, our kickoff with the ACL Challenge actually started in March of 2020. And you'll see the next bullet says that we identified our partners and providers by September of 2021. Just a little reminder that we had a small pandemic during this period of time. So there was some challenges in finding our partners who could work with us on this challenge, because everybody was busy trying to figure out how they were going to provide remote services. Plus, there's some logistics there. Whenever you're starting a pilot like this with so many different providers, you've got to find people that are ready and willing at that time to start a pilot with you. So we were very fortunate to find Care South Carolina and eClinicalWorks and our CBO partners to want to come together. Once we found our partners, the completion of the technical design and workflow really wasn't that difficult. We completed that by October of 2021. And then we started pilot testing in our lower regions, in our development and our SIT regions in March of 2022. Of course, like Ochin described, we had some hiccups there, and we completed our lower region testing in December of last year, just a month and a half ago. We're going to complete our pilot testing in April of 2023. So I've alluded to some of the challenges. Beth, I'm going to hand it back over to you to talk about some more.
Yeah, definitely one of our biggest challenges is that there is no statewide HIE in South Carolina. And so there's not a standard point of connection or place of connection. Those first and second challenges kind of walk hand in hand together. There are a wide array of EHR platforms used throughout South Carolina. I'm sure that the rest of y'all from other states also see that and recognize that even between state agencies, EHRs can be very different. So absolutely.
Yeah, and then one of the challenges that I was alluding to is just, it's not so much the technology, it's the logistics and rolling something out. ECW was going through a major system upgrade right in the middle of our project. So we had coded our API one way, and once that that upgrade was made on their end, we had to kind of make some tweaks on our chart. So I think managing the logistics is much harder sometimes than managing the technology.
Absolutely. As far as what success looks like for us, first we want to talk about some considerations. So it's been a while that we've been working on this, and one thing that we would want to consider were we to start another project like this, or would suggest for y'all to consider, is single sign-on and making it as easy as possible to navigate between EHR and other Sharp platforms. And then also looking at implementation and adoption best practices. So we have lots of different types of users, right? And so when you're asking someone who's very comfortable with an EHR to use the same software as someone who is a volunteer at a food pantry that's there maybe once a quarter, you're asking two very different types of users to use that same platform. And so looking at those implementation and adoption best practices on a audience basis. So looking at it from those different lenses of who will actually be using the software. And then also recognizing that there are current job market implications that can impact success. So if you're looking at implementing this in a position that has a high turnover rate, or at an organization that does have high turnover, that's also going to implement success or impact the success of the project. As far as key performance metrics that we are and will be looking at, we're looking at system usage, referral outcomes, and client outcomes. And I will share, as far as system usage goes, we've seen some really hopeful metrics in the last couple of months. So between 2021 and 2022, we're seeing an 8% increase in the number of resources accessed at one time when a user is helping a patient access those resources. And between the first half of 2022 and the second half of 2022, we're seeing that at a 12% increase in the number of resources accessed at one time, which is so incredibly heartwarming. And I'm really excited about the possibility of what's next and watching that climb further. So.
Amazing. Thank you, Beth and Katie. That was a terrific presentation. I do see a quick, sorry, not quick, some questions in the chat, if that's okay with you all. I know Ryan asked a little bit something about Athena Health, so we're going to take that offline. I know we have some members from Alliance Chicago that I will connect you with, so we can hopefully answer that question for you. But I did see a question coming in from Ruth. Beth of Katie, can you talk a bit about how practitioners are using the Gravity VSAC intervention codes? Do they use free text, or are they documenting care through the intervention codes? Have you been able to monitor which intervention codes are being used?
Beth, you want that one, or you want me to take it?
So, Katie, if you have the information, yeah, absolutely.
I think we'll get back with you on some of this, but I do want to say that we are not using free text. There we do have our codes that we use, but when Beth is talking about our usage statistics right now, she's talking about our closed loop referral. Remember that our connection between our EHR and our social care referrals is still in our pilot phase. So we won't complete that until April of 2023, where we're then going to really roll it out. And so we'll be able to get back with you on the monitoring the intervention codes at that point.
Wonderful. I'm just looking at the chat and see, I know someone asked about your partners and you already went over that. Just a friendly reminder that we are posting the slide deck as well as a recording on our Confluence space. So anyone that came a little bit late will be able to catch up with no problem. So I don't see any further questions. Thank you, Beth and Katie. We'll now segue into our third wonderful presenter, John with May June. Perfect. I see your slides. Thank you.
Great. Can you all hear me okay? Awesome.
Yes, we can.
Okay. Thank you for the opportunity opportunity to speak and for the opportunity to have been a part of the ACL Social Care Referrals Challenge and all of the wonderful efforts through Gravity over the last few years. My name is John Manning. I'm CEO of May June. I'm an emergency medicine and informatics physician. I practice clinically, took care of kids last weekend over in the evening, took care of adults a few days before that. It's interesting because May June has members from, North Carolina, which is where I live and practice, Georgia, Pennsylvania, Maryland, and we've implemented integrated care for kids social care referrals processes in New York and Connecticut. Oh, I'm sorry, New Jersey and Connecticut. So we're kind of all up and down the East Coast at this point in terms of what we've done and where we've expanded, and certainly we're looking to build further. On the call with us, Gray Falkenberry is our Chief Technology Officer, who is, I'll say, a huge driving force behind Firefly, which I will define. Dave Walsh is our Chief Strategy Officer, who's also on the call. Our emails are here and in the slides. Please feel free to reach out to us. We are happy to chat and to work and collaborate with anybody. A bit about May June. We have about 50 plus years of experience in direct clinical practice. A lot of the people that are a part of May June still practice clinically. For those that have that background, we practiced in 8 countries, across 4 specialties of medicine, and wrote a textbook about care for children in developing countries. We have a lot of background in operational, working with states Medicaid, regional and departmental leadership within the health systems that we also work, and various advisory roles. We have, and I guess we get to still say this, the world's only healthcare trained Google developer expert in Dart and Flutter, which is really cool to say. We also have cloud DevOps engineers, and we've built products for the integrated care for kids programs, for EMS agencies, and for specialty organizations. We are happy to build things in and out of the open source space, depending on our users' needs. The first application that we created was an EMS protocols app that is open source. And the first month we implemented was used by about 1,200 EMTs in 7 cities and 12 counties. We built things for the specialty of emergency medicine and also Questionario, which I will define now. It's similar to what Katie Morgan from ProTech had mentioned as a white label application. Technology done right is best invisible. And the efforts that we've built, that we've internally referenced as Questionario, is essentially a white label app that can be themed and designed in a number of different ways. For New Jersey's integrated care for kids, it's Health Story. For Connecticut's, it's Health Journey. And it can match the theme of the groups that we're working with. So we're part of the tier 3 in terms of the pilot participation. This is a collaborative. It is not the one thing that we've done within May June, and really we depend on our collaborating organizations very heavily, and we worked together and we tried essentially coming up with something that at the time didn't really have a lot of use cases and examples, and now we've built this out in ways where we can also see how that test scales and implements in other ways. So we're pretty heavy into the use case 1, which is document SDOH data in conjunction with an encounter. We have done a little bit of effort in relation to tracking and things along those lines. And as I mentioned, this is heavily partnered with the Integrated Care for Kids programs, with other vendors like Open City Labs and Zane Networks, and with other open source organizations like the Interoperability Institute. For us, within May June, we're pretty heavy on that left side of capturing, storing, and mapping data, and very focused on the patient side. And as I mentioned, we're working through additional use cases that work from the to help make it as easy as possible to start initiating some of these referrals. Last year at the CMS Connectathon, there was a nice end-to-end demonstration from our company, from Zane Networks and from Open City Labs, where we demonstrated the IG in its entirety. And certainly we've, since that time, since July of last year, worked through trying to see how many different ways we can work with this and what other settings. So one thing that I'll mention that is really important for us, and one of the things that we provide to the community as a whole, is what's called Firefly, which is defined as the FHIR standard with Flutter library integration. And we do have permission to use the title. It is not an endorsement from HL7. So essentially, if you've not heard of Flutter, Flutter is the one code base that you can use to make apps for any screen. And by any screen, I mean it compiles native to Android phones, to iPhones, to web, Mac, PC, and Linux with one code base. It's just barely 4 years old. It was released December 4 years ago. Since that time, over 700,000 apps have been published to the Android Google Play Store. It's actually the third largest repository on GitHub. People who develop in it love it, and we love working with it. And so one of the things that we did here on this right side was we took the published versions of FHIR, R4 STU3, DSTU2, and the R5 preview, and allowed you in your cross-platform Flutter application to work with any of those resources. So you take data in FHIR, you display it with Flutter, and then you connect it back to FHIR. And to date, we've used Google Cloud's Healthcare API, Happy in its iterations, including Interoperability Land, AidBox. And to date, we've worked with simulated EHR environments. We have not yet had the privilege of working with a product that is fully integrated with EMR yet, but that is one of the things that we're actually looking to do next. In summary, Firefly is about 10 million lines of code, according to 3 separate code counters, with a very high estimated cost to develop. And a lot of that is through automation to make it easier. So whenever FHIR gets updated, we can update that as well to make your connections to this a little bit more streamlined. But a lot of it is also building upon the functionality that's provided within FHIR. And I, with frequency, will include this slide because I love the concept of building blocks whenever you're thinking about interoperability and interchangeability. So I think of FHIR as one of those building blocks. Flutter is another one. Firefly is our next block up that we provide for everybody. And then Questionario is that next one that we've provided to try and make our lives a lot easier as we're building questionnaire assessments. So looking as a whole, and these were the pilots that we had gone through, and I know we have some colleagues from Open City Labs here. Hi, Matt. Hi, Brian. That had in November demoed their and shown their side of the Team Firefly section for the Social Care Referrals Challenge. And today we're going to focus a little bit more on the patient's experience as they're first getting into and seeing, what these assessments are. We're, again, we are a very small part of a very large multi-stakeholder organization. The Integrated Care for Kids program for all of its states, it's a CMMI, Center for Medicare, Medicaid Innovation funded entity that for New Jersey is pretty heavily a lot of oversight is through Hackensack Meridian Health and the Visiting Nurse Association of Central Jersey. For Connecticut, it's through Clifford Beers Community Health Partners. And in the slide deck, we'll have links over to this as well, both here and at the end of this the end of this presentation. Just taking the 1,000-foot view of what we did and what we had figured out as a collaborative together with the names that you see here. At the start, we were looking to how best we can capture data. And for that, we follow the structured data capture implementation guide and workflow. How best we can connect through this with the SDOH data, which if you think of, the glue for all of this is FHIR server. And there are multiple vendors that are connecting in through this so that it can be as easy as possible to step up and to get these assessments completed, to make it easy to see which patients would qualify, and then to make it easy for the closed loop referral process. And then looking through some of the stuff that we've done since, connecting through open source sandboxes to further demonstrate some of those capabilities. That's essentially where we've sat. So Questionario by definition is that white label application, which has different brands depending on the group. I think this is often just something that is easier shown. But when you think of the entire user flow and what we're using, so for the assessments, the FHIR server is what we're using, which is, we're all connecting in and working with that. The task is kind of the glue that allows us to both assign the right questions to the right patient or caregiver. And when everything is complete, from the IG, it's the condition that helps decide, where, which referrals it is that you actually need and everything like that. Our side is essentially, it's not as simple as I answer a question and I create a condition that says, do you have food insecurity? Yes. And that was for the needs of our client. So rather than that, essentially, and for New Jersey and Connecticut, they have different external vendors of which patients qualify. They're even different age groups. Once they get that, they'll have an email or a text that gives them, click this link. Once you click that, you'll get a one-time passcode that's available for 5 minutes. And then you actually open the questions, you fill them out. Some scoring happens that determines what your overall risk from a medical perspective and a social perspective, which then determines which patients qualify for the closed loop referral process. Looking at it a different way, if you're thinking kind of a lot in terms of the social care referral workflow, we're pretty heavy on that patient side, and we integrate very closely with Zane Network's operational data hub. We're happy to integrate with other systems as well. And when you're thinking all the way into the closed loop referrals process, that's what our colleagues from Open City Labs have done. And they are doing that with New Jersey's Integrated Care for Kids. We're happy to work with other organizations, just as that point of interoperability and interchangeability. So without further ado, I think it is worth at least just showing briefly. So this is MELD, which is the Interoperability Institute's open source EHR sandbox. They demoed at yesterday's Project Unify session. We have an application that, just to show you that smart on FHIR launch, I will open what we call a recipe book or recetario, and pick a patient, and let's pick Susan Baker, sure. This is doing the standard smart on FHIR authentication and authorization from the provider's perspective. And what I can do essentially here is select any questionnaire, or what a plan definition is, a group of questionnaires. And we're just going to pick a very short 4-question questionnaire, and this wouldn't be in anything apart from the demo. But essentially, once you send this on the patient side, what will happen is you'll get a quick link that says, all right, you have this task, here's your one-time, or here's your link to log in. You essentially do the same process of authentication and authorization through the standard OAuth 2 protocol. And let's see if this will actually work. Yeah, great. Always fun to do something in a demo. And now I have a questionnaire that shows me 4 questions, and I can fill them all out and then hit submit. And that's great. So in the other side, and just for time's sake, you can go and you can see that there's a task. With each question, you can see how they're filled out, and certainly can go from there. What we've tried to do with the point of, let's do one thing extremely well, let's scale it, and let's see how many potential use cases we can have for that. We can do different themes, different colors, different schemes that actually work. You can have checkboxes, you can have radio buttons, you can have dynamic questions. So for example, if I fill out all of these questions for Connecticut, and one of the things, by the way, that we learned the hard way was we used to have next and previous for the different questionnaires. One button that will immediately bring me to that was a huge benefit, both from the patient's perspective as well as from our perspective, because it's literally the same thing that I'm filling out throughout, and it makes your life a lot easier from your perspective. If I'm using a slider as a good example, and I select here a higher number, it will actually update and dynamically change the types of questions that are there. That's one of the things that we had figured out that was important, just because you don't want to have to answer these questions that are non-relevant for you. If I only have 4, I'm going to just answer the 4. That one button, again, where it essentially does everything that I need, can make your life a lot easier. And then we'll see essentially scored risk of what you have for X, Y, or Z. Looking at from the this integrated care for kids workflow, rather, as I mentioned, we're looking at not just one group of questionnaires. For Connecticut and for New Jersey, it's 17 different age groups with a total of about 40 unique surveys for one of them and about 45 for the other one. So we're essentially managing, if you include that as well as a lot of the other ones that we've done in multiple languages, we're looking at about 60 unique FHIR questionnaires, probably about 15 value sets that allow it so that if you're answering a question for one, it can work for the others. And if your language is in Spanish on your phone, or if it's in Haitian Creole, Flutter supports 80 languages out of the box, but everything is in Creole. They don't support Creole. We figured out how to do custom languages too. And essentially what we've gone through and what we've learned, from the start and kind of where we are right now, we were identified as a part of this project back in March of 2021. We officially went live with a pilot with Zane Networks in December of 2021. Since that time, about 800 patients over the extended pilot have filled this out from start to finish, all the way to getting their scores and assessments. There's also operational data hub, which is an active development to make the workflow easier from the community workers, the community health workers that are a part of both programs. And then when you look on the other side, they've been live with the pilot with Navigator 360 and Open City Labs since around Q3 of last year. So essentially what we've found through all of this on our side was there was a lot of effort. It was quite, we weren't just doing one survey. And so that's really where we had to focus into of how can we match multiple users? How can we match multiple languages? How can we get this as robust as possible and potentially from scale from that perspective? And so I'll end with one final comment because I know we're a little bit limited on time, but just in terms of what we learned and the lessons that we had and trying to make things easier for other people. So last I had checked, I think we are still one of the few that have published the structured data captured workflow as an example from end to end, where we actually show how we got those scored assessments and how we followed that. One thing that we had learned when we had originally built an open source application to screen assessments, where we started with Prepare, we had essentially pulled in all of the content into essentially one spreadsheet that we would then pull into the application. And that included a lot of the questions that were specific to Prepare. But we realized that it made a lot more sense to try and embed that into the FHIR survey so that you could work with any vendor and have your content directly embedded into your questionnaire. And so essentially we've created this, I'll say it's like a master spreadsheet where you can make your questions, you can build them from scratch, you can include your language translations. And really what we want to do at this point is we want to test this in other environments. We want to test this in other settings. We want to connect to other, I'll just say, EMRs, referral platforms, et cetera. We want to try and make this as robust and interoperable as we can. And we want to see how robust it is to actually show and display those types of questions. Because, from the patient's perspective, you want this to just be one stop streamline. You get a text, you get an email, you open it. It's either a native application or an embedded web app. And then you just answer whatever questions you need and move on. And, as we figure that out, even that workflow sometimes can have its own opportunities and challenges. So that's what we've done over the last 2.5 years in a number of different settings. And thank you again to our partners, and thanks for the opportunity to speak.
Hi, John. Thank you so much. I see that Gray has been supported with some answers via the chat. I was hoping maybe if you can do like a 2-for-1, just speak a little bit about how exactly how you're using the FHIR resources. I think a question here came up with which FHIR resources are you using for your questionnaire responses, questionnaire or observation? And then if you don't mind speaking a little bit about the gravity terminology codes. I know you mentioned, I think in the answer is that they're captured depending on the questions asked, but we can close a little bit with, those two.
Sure. Yeah, absolutely. And I'll link this over if Gray hasn't done this already. But essentially what we did with our the actual FHIR resources. So the service request and the plan definition, is, I think, the more important one, which says for age, if you are age group 12 month, you get these 6 questions and these value sets, and this is how you get everything scored. Or versus if you're 15 years old, you're going to get these questions and all of that. So we're essentially using the plan definition to decide who's getting what questions, how it's going to be scored, and what we use value sets pretty extensively to make it so that if it's yes, no, I don't know, you're not going to have that every single time embedded into your to the same questionnaires. So the task is the glue that has, and if you actually click more on here, we'll have examples on this, but it's the glue that has the questionnaires as your inputs, and then some of the outputs are, and this is unique for each patient. So once you have this, the questionnaire responses get added to your output further down. We are also using this for where that measure report is, which is how everything gets scored at the end. And we're using this to keep track of what's my progress. Because I mentioned that the questions may be, there may be 4 questions in a questionnaire, but there may be 9 depending on how you're actually answering it. So we found this was that one easy place to try and have all of that status together. And then from the next perspective, the measure is what says, okay, based on how you're answering in different questionnaires, how do we put all this stuff together as to low risk, medium, or high? And the measure report is the thing that actually will show you your low risk. And then our colleagues will then take these data fields and pull that over. Answering your final question about the condition. So the condition for these projects is a little bit different than the condition that we would create with, as a little bit more simple of a use case where you just have these questions, here's your answer, that creates a condition. So that's a different workflow than here of how complex is the patient? Do they qualify for this? And then can we create these conditions, which then will trigger the referral?
Wonderful. I know we're coming close to time. I just see your team members in the background supporting with answers. Again, I think I just want to take a moment to give a virtual round of applause to all of our presenters. They have done such a great job of really sharing, I would say, comprehensive and complex concepts into real world examples. So just really want to thank you all for being here, being part of this community of learning. We are coming close to an end, and again, just many thank yous. If you see any questions that were not answered, please let us know. We'll definitely continue to monitor the chat. We do save and go back to see if we answer some of the questions. So in this last minute or so, I'm just going to close us out, giving you all a little bit of our meeting schedule. So we just completed our meeting number 5, and we heard the wonderful work that's coming with Civitas Networks for Health. And we will be having our meeting next month on March 30th, where you will hear from other participants and extend the schedule until September 2023, as mentioned. As next steps, if this is your first time joining, we welcome you to sign up to our listserv via Confluence. The link is in the chat. And really, this is a way for you to get added to the calendar invite, stay in the loop with announcements, opportunities. We send correspondence via email quite frequently, so you have kind of a heads up when our meetings are happening. And Demery and myself are here to support you with any questions in between calls. We want to thank you all for being part of this national standards implementation process. I think I personally learned something every day from all of you. Just want to send you all a big applause again. You are welcome to join us via social media, get to know what we have coming down the pipe. And if you would like to sign up as a sponsor and really help us develop blogs, manuscripts, other dissemination materials, we have our virtual arms open. Without further ado, I'll give you back your time. Thank you again. And we are right on time, 4 p.m. Appreciate everyone's attendance. Thank you.